Okay, so let me give a little bit introduction first. So welcome everyone on this webinar on EKG. So first of all, I'd like to give a little bit introduction of ourselves. So I'm Afifa Idris, president of Karachi Medical and Surgical Society, and also country manager at Biospiel, which is a pioneer in web revolution in medicine. And they are working to basically bring doctors from all around the world together to work with them. So I'll share the LinkedIn links of both organizations in the chat box so you guys can know about them later. So first of all, I would like to thank Dr. Charles for coming here, for helping us to arrange this webinar. And we are very happy to have you here with us, sir. And I would like to inform you guys that we will be taking questions at the end. So you guys can type your questions in the chat box, and we will answer those at the end, or maybe I'll read that out for you. So thank you so much, Dr. Charles, for coming, because we are really looking forward to learn from you. You can start now, sir. Thank you.
Thank you very much. Thank you very much. And I would say good morning, except for you, it's good evening.
Sir, it's evening.
So I have been practicing cardiology and internal medicine for a long time. And I've been interested in EKGs ever since I was a cardiac fellow. For the last number of years, I've been putting together some of these talks, and especially the last six or 7 years, well, more than 7 years anyway, presentations on ECG interpretation. This is one that I developed a couple of years ago for presentation to primary care clinics. And it covers the basics of electrocardiography. You can't, of course, go over all of electrocardiography in an hour. So there is some picking and choosing of topics. I've titled it the A to Z of EKGs, AFib to Zebra, and I'll explain what that is as we go along. This is a picture of Dr. Einthoven's first electrocardiograph machine, 1902. You'll notice that this fellow does not look very happy with his two hands in buckets of saline. We've come a long way since that time. And to start our review, we will review the anatomy of the cardiac conduction system. So the cardiac impulse starts in the sinoauricular node, the SA node, located here in the right ventricle, where it is joined by the superior vena cava. Impulses travel through the atria to the AV node, then to the common bundle or His bundle, and then to the bundle branch. The vascular supply to those structures is something as follows. In 60% of people, the blood supply to the sinoatrial node comes from the right coronary artery, and in 40% from the left circumflex. The AV node is fed in 90% of people by the right coronary artery, and only 10% by the left circumflex. The right bundle branch and the left anterior fascicle of the left bundle branch are fed by the left anterior descending coronary artery, and the posterior fascicle has a varied distribution. So the impulses, as they travel through these through the cardiac conduction system, are reflected in the surface ECG. This gives you a depict. The SA node does not alter the baseline, so we don't record that on the surface ECG. As the impulse travels through the atrium, a P wave is written. The P wave represents atrial depolarization. The PR segment represents the delay in the AV node. And then the QRS complex represents ventricular depolarization. Repolarization takes place in the ST segment and the T wave. It's written in the peripheral, the surface electrocardiogram, and then things go back to the isoelectric line or baseline. This is called Einthoven's triangle, and shows the hookup of the what are called the limb leads, so that there are 3 bipolar leads and 3 unipolar leads. The bipolar leads are lead 1, which is positive in the left arm and negative in the right arm. Lead 2 is positive in the foot and negative in the right arm. Lead 3 is positive in the foot and negative in the left arm. The right foot is a ground. The unipolar leads have a central neutral site, so that AVR represents the right arm. Oh, here we go. The right arm. AVL represents the left arm, and AVF represents the foot. There's also progress across the chest leads. So the chest leads are in a different plane. Chest leads are in a more or less horizontal plane, more or less. The impulse travels, the beginning of the impulse, as it written in the ECG as the QRS complex, travels from left to right across the intraventricular septum, giving a small R, not always, but small R in lead V1, and a small Q in lead 3, V6. And then it travels across mostly in the leftward direction, so that there's an S wave in lead 1 and an R wave in lead 6. And as you see here, there's a progression. There's what's called R wave progression across the anterior precordium, meaning leads, so that the R wave should grow from lead V1 through. That allows us to calculate what's called the axis in the frontal plane, using leads 1, 2, 3, and AVR, AVL, and AVF. I like to use just 2 leads in order to calculate this. Makes it easier. Lead 1 is the horizontal, and lead AVF is the vertical. So that if you look at the QRS complex in leads 1 and AVF, you can calculate or figure out what the axis is. So positive in 1 and positive in F puts it in this quadrant, which is normal. Positive in 1 and negative in F puts it in this quadrant, usually beyond minus 30, beyond here, called left axis deviation. Negative in 1 and positive in AVF puts it in this quadrant, called right axis deviation. This negative in 1 and negative in AVF is an extreme right axis deviation. It's a useful thing to think about when you're looking at wide complex arrhythmias. In the United States, we call it northwest axis, and this happens to be a picture of the Seattle Space Needle in Seattle, Washington, located in. If you're not aware of the U.S. map, located in the northwest quadrant, the northwest portion of the United States. Now, we encourage a systemic approach to interpreting ECGs. So look for rate, look for rhythm, look for intervals, PR, QRS, QT, look for axis, look for hypertrophy, chamber enlargement, or wide QRS, which would come in here, wide QRS suggesting bundle branch block and ischemia or infarction. There's a systemic approach to arrhythmia interpretation as well, with 5 key parameters. First, are there P waves? If there are no clear P waves, are there signs of any atrial activity? Is the QRS wide? Okay, and we generally look for 120 milliseconds or 0.12 seconds as the definition of bundle branch block, but anything over 0.10 seconds would qualify as a wide QRS. And then the 3 R's: rate, regularity, and related. That is there a specific relationship between QRS complexes and neighboring atrial activity? This is a normal ECG. It has a normal P wave. The PR interval is all of the intervals are normal. As you can see, the axis is about, is positive in 1 and positive in AVF, about 15, 20 degrees, something like that. And there is progressive R wave. There are progressively increasing R waves across the anterior precord. Okay, so here's the next ECG. What is the axis on this ECG? Left, right, or normal? It has a positive deflection in lead 1, negative deflection in lead F, and if you look here, right, positive in 1 puts it to the right of here, negative in AVF puts it up here. So this is left axis deviation. What's the axis here? Negative in lead 1 puts it to the right of the vertical, and positive in lead AVF puts it here in the right axis quadrant. Now, widened QRSs, as I pointed out a minute ago, suggest bundle branch block. When the right bundle is blocked, the clinical electrocardiogram writes a complex like this in V1 and this in V6. The way to distinguish between right bundle and left bundle is look in lead V1. If it's up, if it's right; if it's down, it's left. Or if it's a positive abnormal deflection, will be a right bundle branch block. A negative abnormal deflection. Right bundle in right bundle branch block, the initial depolarization of the ventricle is normal, and then secondarily comes back toward the right. Remember, lead V1 is located to the right of the sternum. This also writes a small wide S wave in lead V6. Not very prominent and not terribly useful for diagnosis. Here's where you make the diagnosis. The left bundle branch block, most of the impulse, the vector goes toward the left, and so there's possibly an R wave, but if so, small and dominant S wave. In lead V6, there's a dominant R wave, possibly splintered. So this is a ECG with a bundle branch block. Which one, right or left? Look in V1. And you can see that the abnormal deflection goes toward the right. Therefore, this is right bundle branch. Here's another bundle branch block, wide QRS complex. And look in V1, the dominant wave is an S wave or away from V1, meaning left bundle branch block. Also notice that the PR interval is prolonged on this particular ECG, suggesting AV conduction delay. Instead of calling it first degree AV block, we usually call it AV conduction delay. My general approach to arrhythmias is something like the following. First, look at the patient. There's actually no substitute for looking as a general statement. But in this context, what I mean is the patient hemodynamically stable? If the patient is not stable, you may need to cardiovert that patient no matter what the arrhythmia is. If the patient is stable, you have time to look at an ECG and make an appropriate diagnosis. Does the patient have structural heart disease? Patient does not have structural heart disease. That has certain implications. If the patient does have structural heart disease, that has other implications, including the origin of the arrhythmia and some of the drugs that can be. Look at the ECG, and I've already reviewed this with you. So we'll go on. Look for and treat precipitating or reversible factors, such as electrolyte imbalance, ischemia, drugs, hypoxemia, hyperthyroidism, and so forth. If you correct these, the arrhythmia will be treated and may go away. And finally, treat the arrhythmia if necessary with drugs, devices, etc. So here's another case of a 81-year-old woman who came to our clinic complaining of a cough. Her daughter thought she needed an antibiotic. We noticed that she had a rapid pulse. And so we did an electrocardiogram. The interpretation of the computer is sinus tachycardia with PACs, premature atrial complexes. You agree with that? Is that what this is? This is a rapid, narrow, complex, irregular rhythm. And it doesn't take much to guess that this is atrial fibrillation. If you look at V1, you can see these fibrillatory waves. There is no single P wave preceding each QRS. And so this is indeed atrial fibrillation. And her cough was related to heart failure. This is one of my favorite slides showing or illustrating atrial fibrillation. So if you look at sinus rhythm, you see that coordinated conduction and contraction of both atria and ventricles. On the surface ECG, it will look like this, EQRS. Okay. With atrial fibrillation, there are upwards of 350 or 450 wavelets of ectopic fibrillatory waves, as illustrated here, which bombard the AV node. But the AV node will not allow conduction that fast. So many of these impulses are blocked. They get more or less penetration into the AV node, which is what's responsible for the irregularity of the heartbeat. So here's a gentleman who came to the clinic one day. He has a wide complex rhythm, but what rhythm is responsible for this wide complex rhythm? It is irregular, pretty obvious, right? P waves do not precede the QRSs like sinus P waves, and you can clearly see fibrillatory waves in the lead V1. Here's a V1 rhythm strip down at the bottom. And so this is atrial fibrillation. And the approach to atrial fibrillation, as suggested by the European guidelines, is that we take the ABC approach. So the ABC approach is as follows. A is for anticoagulation in order to avoid stroke. We identify patients who have low or a higher risk according to the CHADS VASC score. It's the bleeding risk to make sure it's not a high risk bleeding patient. Use oral anticoagulation almost always. B is for better symptom control, assess the symptoms, the quality of life and the patient's preferences, optimize rate control, and consider a rhythm control strategy. And the data currently is more and more favoring early rhythm control. And C, treat comorbidities and cardiovascular risk factors with lifestyle changes, including obesity reduction, regular exercise, and a reduction in alcohol use. Now we turn to heart block. To begin this, I give you the heart block poem. If the R is far from P, then you have a first degree. Longer drop, then you have a winky Bach. If some P's don't get through, then you have a Mobitz 2. If P's and Q's don't agree, then you have a third degree. And so we have two examples. These happen to be old examples because these are single channel ECG dating back many years, but they illustrate the point. So which one of these patients needs a pacemaker, patient A or patient B? Well, what you can see is that in patient A, there is a change in the PR intervals before the drop beat. So you have this PR interval, and you have this one, and then a drop beat. Same thing happens again. This one, the PR intervals before are all the same. before or after the drop beat. So the answer to the question is patient B. Patient A has, so second degree AV block, first degree AV block or delay is one-to-one conduction, where every QRS is preceded by a P wave. Second degree AV block is where some beats are conducted and some are not. This shows classical Wenckebach conduction. So the PR intervals are 210, 380, 540, drop. Notice that after the pause, the PR interval shortens. That's because this takes place in the AV node, and it's a matter of refractoriness. Okay. This, on the other hand, is Mobit's block. All of the PR intervals are exactly the same, regardless of whether there's a pause or not. And so that represents Mobit's block, and that takes place in the His-Purkinje. And this is what happens when somebody who has a Wenckebach type of AV conduction exercises. So this was a 69-year-old patient of mine who presented with exertional chest pressure and with restless PR interval, longer PR interval drop. So this is a Wenckebach conduction. And when he exercises, you'll notice that there's conduction improves, and there's now one-to-one conduction. Well, there's a one-to-one conduction. So if conduction improves with exercise, that suggests that you're dealing with Wenckebach. If conduction worsens with exercise, suggests that you're dealing with Mobit. The next slide shows some of one of the consequences of Mobit block, which is why they need pacemakers. All the PR interval fixed until there is no conduction. So this is like all or nothing conduction. You either conduct or you don't conduct. In this case, quite a bit of time goes on before conduction resumes, again with the same PR interval. This person needs a. Here's a 48-year-old woman who presented with syncope and then with chest dystonia. And what you can notice is that the P waves have no relationship to QRSs. If you think about what the PR interval might be, there's this one and this one not conducted clearly, then this one, and so forth. This is third degree AV block. And the reason is shown here because there are ST segment elevations in 2, 3, and AVF, consistent with an inferior myocardial infarction. And if you recall, the blood supply to the AV node comes from the right coronary artery. And so that's why she had AV block. And with inferior MIs due to right coronary occlusion, the heart block usually recedes and aches when the ischemia is treated. This is a 67-year-old woman with atrial fibrillation and long conversion pauses, so-called tachycardia, bradycardia syndrome. So here she is in atrial fibrillation, where she converts. I think these three people. And then there's a long pause, a couple of 8 beats, and then it goes into sinus movement. So this person will need a pacemaker in order to treat her atrial fibrillation. Now, here's a different problem. This is a 49-year-old man who was awakened from sleep with 30 minutes of left-sided chest pain, which subsided. Well, you know, he was not present, say, by the time he got to the emergency department. And his examination was normal. Does this ECG have any clues as to what's going on? The answer is yes, it does. Notice that there are T-wave inversions, leads V2, V3, and V4. This is well, I'll show you what happened. His chest pain returned while he was still in the emergency department, and look what he has now. Marked ST elevations across the precordium, the inferior myocardial infarction. And so these T-wave are suggestive of a lesion in the left anterior descending coronary artery, as described by Hein Wellens. And there's the lesion in the left coronary artery. And they're thought to be reperfusion changes. Let me show you the evolution of the ECG in ST elevation MI. This is after an acute coronary occlusion, the ECG will change as follows, providing there is no reperfusion. Okay, so the first change is a hyperacute T wave, a very tall T wave, followed by ST elevation, the development of Q wave, the ST segments come down to normal, T waves invert, and you're left with a Q wave. And the Q wave may recover over the course of time. However, if at this point there is reperfusion, then you'll get these T-wave inversions as noted here. And so what's thought to be the etiology of the Wellens syndrome, which I just showed you, this was named by Hein Wellens, a Dutch Dutch cardiologist, as Wellens syndrome. What is thought to happen is that there's occlusion and then reperfusion, causing the T wave inversion. Then what must happen here is total re-occlusion. This shows the anatomic locations and supplying coronary arteries of acute myocardial infarctions. So that leads 2, 3, and ABF represent an inferior infarction, more commonly right coronary than left circumflex. The leads V1 through V4 are represented representative of the left anterior descending coronary artery. Leads V1 and V2 are called septal, and 3 and V3, V4 are called anterior, which often get all of those together. Leads 1 and ABL and V5 and V6 are thought to be circumflex, are thought to be lateral due to either left circumflex disease or diagonal disease. Okay, now here's a case of a patient with recurrent syncope over the course of 24 hours, who came to the emergency department with this ECG. These are two ventricular premature beats. That's not what I'm suggesting that you look at. It's sinus rhythm. You can see it here. Sinus rhythm. But there's something about this ECG. What is it? Look at the T wave. Look at the QT interval. The QT interval is prolonged. The normal QT interval should be less than half of the RR interval. Long QT is where the QT is longer than the RR interval. And so this is, this patient has long QT, has a long QT, or even corrected long QT, and makes her susceptible to a rhythm disturbance which caused her syncope. Do you know what the rhythm disturbance was? Polymorphic VT, or Torsade de Pointe. Torsade de Pointe is French for torsion of the points. So here's the rhythm disturbance illustrated here. This is not hers. Here's the rhythm, wide complex rhythm starts. You can see that the points twist from up to down, up, and so this is a particular kind of ventricular tachycardia, and there are certain recognizable risk factors for prolonged QT interval, for one thing. Use of prolonged QT prolonging drugs is another. Concomitant use of more than one QT prolonging drug, which is really why I show you this, to alert you to this, other factors of heart disease, heart failure, and stage. What I call the three hypos: hypokalemia, hypomagnesemia, hypocalcemia. Treatment with diuretics causes causes hypokalemia and hypomagnesemia, and bradycardia of almost any cause. These are drugs. This is a very short list of drugs which pose a risk of profound decline. The actual list is about a page and a half long, single space. So there are many drugs which can do this. But classes are antiarrhythmic drugs, antibiotics, which is, as we say, one of the reasons I highlight this, so that folks are aware of the Torsade risk with these antibiotics, particularly with if you give an antibiotic to somebody who's already on another QT prolonging drug. Antibiotics, haloperidol is probably the worst offender. And then a number of others, including methadone, hydroxychloroquine, and Odense. Okay, now we come to the zebras. United States and Western Europe are areas of high Christian populations, and so we celebrate, not me, but we celebrate Christmas, right? And the children wait for Santa Claus to bring them gifts, riding into a sleigh pulled by 8 reindeer. So the question is, if you hear hoofbeats on the roof on Christmas Eve, what is it more likely to be? Santa Claus's reindeer or a zebra? The answer, of course, is Santa Claus's reindeer. The zebra is, there are very few zebras in the United States. As a matter of fact, there are none except for these animals who are in the zoo. But they're, and the term zebra is used to indicate a rare condition. So that's all an introduction to the following. This is a 47-year-old asymptomatic man who came in for a routine clinic visit. He had an acute inferior MI some years prior at a very young age. I just saw him not too long ago. As a matter of fact, 7 years later, he's doing fine. But look at this. It looks like there are Q waves in leads 1 and ABL. One might think that he had an anterior infarction. Okay, it certainly doesn't indicate an old inferior infarction. But what is the axis here? Well, the axis here is negative, far negative in 1 and isoelectric in AVF. So it's almost minus 180, which is highly unusual for a if we look at R wave progression, however, R wave progression appears to be normal. So what is this? This is, in fact, reversed arm leads. So this is the way it should look, right? AVL should look like that. AVR should look like that. And lead 1 should look like that. If you reverse the arm leads, you see, here's the left arm lead on the right arm, right? You see, it's just the opposite. Comes out just the opposite. So if you go back here, what you see is, if you look in lead 1, there's a negative P, negative QRS, and negative T. In lead 1, that's a hint. And this is really AVL, and this is really AVR. And I'll show you what his ECG looks like at baseline. You see, his axis is really quite normal. His axis is about 0, it's not minus 180. AVR looks normal, lead 1. So this is reversed arm leads. Don't make that mistake. I want to help you not to be embarrassed if somebody reverses the arm leads and they hand you an electrocardiogram and ask you to interpret it. Here's another patient, a 66-year-old man who presented with a 3-day history of cough, congestion, and pain. And look at this. He's got the same axis. Right? Way negative in lead 1, isoelectric in lead F. However, right, is this reversed arm leads? Not so sure. Look at the chest leads. You'll notice that instead of normal R wave progression, it looks like the impulse of the QRSs get smaller and smaller as you go across the chest toward the left. And the reason for that is dextrocardia. His heart is located on the opposite side of his chest. This is indeed zebra. So it's very rare. If we have someone at the hospital who has this condition, everybody comes to look at the chest X-ray and the cardiogram. So with that, I'll wrap it up and leave you with this final thought. Thank you very much, everybody. If we have questions, I see the chat box is full of questions. This is my email address if you have further questions and you'd like to ask. So let me look at the chat box and see what
Thank you so much, Dr. Charles. That was amazing. We really enjoyed that. And you actually explained us everything in a very simple manner. If anybody has any questions, you can write that in the chat box. I think students have written the answers to your questions in the chat box. You were asking
Yes,
me.
yes, I see. I was asking questions and the answers are in the chat box, right?
They were basically enjoying this webinar very much. So they were basically participating with you.
Yeah, okay. I didn't look there for, I thought that people would unmute and answer, but okay. That's fine.
So if anybody has any question, you can write that in the chat box and I'll read that out for you.
Hi, Dr. Schulman. I actually have a question, but I'd prefer to say it out loud if that's okay with you.
Yeah, of course, of course.
First of all, thank you for your presentation. It's really insightful, actually. But if you can share with us, just from your experience in the clinics, what would you say are some of the limitations of ECGs? Could they be misleading at all, for example, in your case?
I'm sorry, what was the last thing you asked?
I asked if they could ever be misleading, perhaps.
Oh,
Like maybe-
yes, they can, which is why I showed you the reversed arm leads.
Right.
So yes, that can be misleading. And what also can be misleading are the computer interpretation.
Right.
I have multiple examples of incorrect computer interpretation. My conclusion based on that is that they're not going to get rid of us yet, of us humans yet. I won't lose my job yet.
That's very assuring for us, since many of us are medical students. So that's good to know. Thank you again for your talk.
You're quite welcome. It can be misleading if the computer interpretation is wrong. We get into some situations where we have wide complex tachycardias and people have difficulty distinguishing the cause, and that can be misleading. But it's mostly the artifacts that are misleading. I see we have a question in the. What is gallop rhythm? Well, cardiac gallop is a sound phenomenon, not an electrical phenomenon. So that if one has a patient in heart failure, particularly in severe heart failure, and listens at the cardiac apex, you may hear a third sound. Instead of lubbed up, it becomes lubbed up, lubbed up, lubbed up, and you need to listen for the cadence of it. It's a sign of heart failure. It is not an electric. I have. Let me show you. I'm going to stop the screen share. Okay.
So we have another question.
Okay, wait a minute. Yeah, wait a minute. I want to show you something else. I want to show you something else. Come on. Oh. Where is it? There it is. Okay. Now, I'm going to go back to the full screen, share my screen, and go to this and share this. Okay, can you see this?
Yes, doctor, we can see that.
Wait a minute. Here. Okay. Can you see this?
Yes, doctor.
Okay.
It's a little
This-
bit black.
Bizarre T waves. Is this an ST elevation MI or hyperkalemia? And look at the bizarre T waves. Here's PQRS, what looks like a baseline ST segment, and then this great big thing that looks like a T wave. Except it's not everywhere. You notice it's not here. Okay, and it continues across here and then, but not out here. Okay, what is this? You see here, the computer says tall T waves consider acute ischemia or hyperkalemia. Well, not really. What this is, these are pulse waves. Okay, what happened here is this person has end-stage renal disease with an AV fistula in his arm, and the electrode was placed right over the AV fistula. And so it is recording the pulse. Okay, see, like this. See, here's the ECG and here's the pulse right after it. And that's apropos of the question about the third heart sound. Okay, that's in the chat. How can we relate different axis with the reading from the Syed, I'm not sure I understand the question.
I think the student is asking about the axis deviation. How can we read axis deviation on the
How can
ECG
we-
strip?
Well, you read it according to to what I've shown you. You know, looking at the lead 1 and AVF and calculating what the axis is. So, how can you interpret them? Well, left axis deviation often means, let me stop this. Go here, and I'll show you this. Hold on. Okay. All right, so if you look here on the right side, you see that there are different causes of left axis deviation. You can have left axis deviation from left anterior.
We can't see your slides. There's no slide share.
Oh, there's no slide sharing. Sorry about that. Thank you. Thank you. How about now?
Yes,
Yeah.
doctor, we can.
Now you can see it. Okay. Okay, see that? You see it?
Yes. Yes.
Okay. All right. So left axis, okay, can you see this here? Over here on the right-hand side? You see left axis deviation can be caused by left anterior fascicular block, the Q waves of inferior myocardial infarction, or Wolff-Parkinson-White syndrome. Left ventricular hypertrophy does not cause left axis, but it's sometimes associated with it. Right axis deviation can be a normal finding. Uh-oh, what did I do? Can be a normal finding in children and tall, thin adults. Right ventricular hypertrophy, COPD, ASD or VSD with right ventricular overload, pulmonary emboli, some anterolateral MIs, and left posterior. I think that's the answer to your question. And then there was another question. Are there any contraindications to ECG? I don't believe there are any contraindications, but there are times when an ECG is of a pretty low value, such as in people who are not symptomatic, in patients who are undergoing surgery, who are young and have no history of anything and no symptoms. ECG is really not necessary and not helpful. Well, any kind of abnormalities, start raising questions, most of which are normal variants of one kind or another. So that's how I would answer your question.
Okay. I think that's the end of the question.
Is there another
Yes,
question?
No, sir. That was the last one.
No, okay.
Okay, so thank you so much, Dr. Charles, for joining us today. It was amazing to have you here with us, and it was an amazing webinar, I must say. Thank you.
Well, it's a pleasure being with you folks.
Thank you, sir. Thank you.
Right. Bye-bye.
Bye,
Bye-bye.
sir.